The vast majority of patients treated with myeloma today as their initial therapy should receive a quadruplet. That is to say, a 4-drug combination that includes a monoclonal antibody, of which we typically use daratumumab or isatuximab, a proteasome inhibitor, which we typically either use bortezomib or carfilzomib, an immune modulatory drug, we typically use lenalidomide, and then some dexamethasone to boot to support the function of those 3 other drugs.
Welcome, everyone. I'm Steve Rosen, the Emeritus Director of the Cancer Center and the Beckman Research Institute at the City of Hope, a hematologist, oncologist, still actively involved in patient care and research. And I'm thrilled that my inaugural guest on the Oncology Insights Podcast is Dr. Joseph Mikhael, an esteemed colleague and dear friend. Joe is currently the Chief Medical Officer at the International Myeloma Foundation, and he also has a prominent role at the American Society of Hematology. Joe, welcome.
Oh, it's absolutely a pleasure to be with you, Steve, as a co-City of Hoper. It's always a pleasure, but more importantly, as a dear friend, I'm very thankful to join you today.
Well, Joe, this is going to be a special podcast because of our relationship. And I'd like you to start off by telling everyone about your unique journey, how you started from childhood all the way now to have a prominent role in one of the major organizations in the nation.
Well, you're very kind to say that, and it's hard for me to talk much about myself, but I can give you the quick summary, Steve, is that I was privileged to be raised by 2 of the most wonderful people that I've ever known in my whole life, and I'm biased, of course, my parents. But my parents came from Egypt. They were immigrants to Canada. They met in medical school in Egypt, had my brother while still in Egypt, but then eventually made their way to Canada because of challenges in the Middle East, and I was born in Canada. So I used to joke even as a child, Steve, that I had 2 doctors as parents, and my older brother went into medical school, and I joked that I would be a lawyer and protect the 3 of them, and that I wouldn't go into medicine. But of course, when I was able to see medicine for what it was, I couldn't help but fall in love with it, and had the privilege of doing my medical training in Canada. I did my medical school at the University of Ottawa in the capital of Canada and my residency there. And then I went to Toronto where I studied hematology, but also did a specialized fellowship in multiple myeloma. I really wanted to care for the sickest of the sick, as it were. And one of the reasons why I was drawn to myeloma is that, sadly, one of my high school friends developed multiple myeloma in his 20s. I'm always excited to say that he's still with us today. He is one of the few individuals who actually did very well with an allo transplant and is now with us over 25 years later. But then I had the privilege of being recruited to Mayo Clinic. And when my colleagues at Mayo Clinic recruited me, they kind of gave me the choice, Steve, should I go to Rochester, Minnesota, or should I go to Scottsdale, Arizona? And I opted for, instead of the frozen tundra of Minnesota, I chose Scottsdale, Arizona. And so I had the privilege in the year 2008 of moving to Arizona, where I joined Mayo Clinic. And as there, I had sort of a duality to my career. I was a myeloma investigator, did clinical trials and work in myeloma, but I'd also in Canada had done my master's in education. And I was particularly interested in educating the future myeloma doctors of the world, but also just the future doctors of the world, and had the privilege of becoming the postgraduate dean at Mayo Clinic. And so always had the privilege of being involved in both of these areas of clinical research, but also as education. And then to bring us to where we are today, a little over 7 years ago, I was approached to potentially take the role of the chief medical officer of the International Myeloma Foundation. I had been working so much with this marvelous foundation that coordinates all the efforts of the myeloma experts in the world, known as the International Myeloma Working Group, but at the same time works directly with patients with over 150 support groups, and really was an opportunity for me to try and exercise my interest in education, my interest in clinical research, and indeed my desire to help those who are underserved. I loved having a clinic in Scottsdale, but I really wanted to serve the myeloma community greater. And because of who you are, Steve, I can't help but say, when that offer came to me, one of the first people I called was you. And I said, Steve, I'm very interested in this position, but at the same time, I don't want to give up my clinical practice and I don't want to give up my academic role. And you didn't say to me, okay, let's send me your CV, Joe. I'll talk to my team about it. Let's think about it. You immediately said, welcome to City of Hope. And I will never forget that day, because you made me feel as part of the family as I still am. And I became a professor at the Translational Genomics Research Institute in Phoenix, Arizona, which of course is an affiliate of City of Hope, and began my clinic in Scottsdale, where I continue to see patients primarily as expert opinion in myeloma, or if they wish to go on to a clinical trial or have advanced therapy. And so we keep open clinical trials and CAR T-cell therapy and bispecifics that we'll be discussing later. And so this was really almost the nirvana job for me, Steve. I have the privilege of still seeing patients and caring for them, which I know is central to your heart because you connect so well with your patients, but also being able to influence the myeloma community, both at the expert level and at the patient level, and if you will, everything in between. And so it has been my absolute joy to be in this role over this period of time. And then lastly, because you made mention of it, I've been particularly interested in continuing to work with the American Society of Hematology, because these kinds of organizations influence the whole of the field internationally. In fact, over 20 years ago, I was on the very first ASH trainee council, where we encourage ASH to say, let's engage our young trainees, our hematology fellows in their early career. And I've had the privilege of being heavily involved with ASH, and I currently serve on the ASH executive as the treasurer. And so it's just been a privilege. It's hard, as I say, for me to talk too much about myself, but I am so thankful for the role model my parents were to me in my both personal life and medical life, and all the incredible colleagues and individuals I've been able to work with since I entered in the career of multiple myeloma.
Joe, I can only say you've been an inspiration to so many of us, and we hope for many years to come you keep up your energy, your commitment, and all of the things that you've accomplished.
If I can add one thing, Steve, just because looking at you reminds me so much that one of the reasons why you and I get along so well, not only because we've been good friends for so long and you were there at my wedding and we've shared wonderful things together, is that often I say, as we become more senior in our career, people tend to go in two directions. They go in the direction where, and sadly, some of our colleagues do this, where they're just really interested primarily still in their own career, and they need to be on the podium. They need to be the first author. They need to have that. And then there are those who say, I want others to fulfill my destiny and others to fulfill my legacy. And when I did my master's in education, my thesis was in mentorship. And one of the things that I love so much is being able to mentor the next generation of physicians going forward. And you have been a role model to me in that. When I engaged you in our Clinical Research Training Institute through ASH, where we take some of the most promising young hematologists and sequester them for a week, where we deep dive into their research skills, where we teach them everything from how to communicate to how to do a clinical trial. Your presence there, having been an experienced cancer center director, having treated tens of thousands of patients, having mentored hundreds of individuals, was a role model to us. So I equally want to reflect to you the role you've had in my career. I think of many mentors I've had in my career, and you have been one where it's clearly been that you're not about Steve Rosen, you're about the field and the patient, and you've allowed us to learn from you to be able to carry that on in others.
Zenetics turns podcast airtime into brand authority. We don't sell ads, we elevate voices. Curious how far your voice can go to become a reference in the industry and attract more leads? Scan the QR code and discover how we can turn your expertise into unmatched brand authority. Let's transform expertise into influence, starting now.
Thank you, Joe. Tell us about the International Myeloma Foundation's major initiatives.
So the International Myeloma Foundation was established 35 years ago, and it was uniquely established by a patient and his wife and his doctor. So Brian Novus was the patient, Susie Novus was the wife, and Brian Dury was the doctor. And they founded this for multiple reasons, but ultimately under four major, if you will, pillars or umbrellas: to do research in the field, to advocate for patients. Susie used to go and speak to Congress about the importance of advocating for patients, for education, where it was important to educate the medical community, but for patients themselves, that patients could know how to go and speak to their doctors about something as specialized as myeloma. And she created educational activities before this ever happened in the cancer world. And then lastly, in support, which has now led to over 150 support groups in the US and another 150 around the world. And so they had wanted to create this foundation that would really be the convener of myeloma, bring the experts together, bring the companies and the industry that supports this together, bring the patients together, and bring the general community together. And so the major initiatives over these last 35 years have been in each of those areas. Perhaps most prominent has been the research agenda, where with the creation of the International Myeloma Working Group has been foundational. So this is now about 350 experts around the whole of the world, and we have common ground in wanting to define the criteria for response and define the disease carefully, to write the most up-to-date and important guidelines for the field, to decide what are the most important clinical trials to be done, not just for a specific product, but what is ultimately going to help the patient, always carrying the patient at the same time. And outside of research, all that we do in education and support, providing support groups, educational seminars, support. We have an info line where patients can call in. And it has just been a privilege of my career to be able to be involved in this process and to see the foundation grow and to see its impact grow truly internationally. I always say the I in the International Myeloma Foundation, of course, is international. And as we were commenting even earlier, creating now clinical trials in Asia, in Latin America, and working towards reversing the health disparities that we see so dramatically in multiple myeloma.
So, Joe, let's focus now on myeloma itself. When I was a fellow at the National Cancer Institute 40 years ago, myeloma was one of the targeted diseases within the branch that I was studying. And at that time, we had two drugs. We had melphalan, an alkylate agent, and prednisone. And the median survival was about 2 to 3 years. Can you share with our viewers where we are now in myeloma in terms of the prognosis? And we'll get into the specific therapeutics in a minute.
Well, Steve, I was a little bit behind you. I couldn't say I was there at the same time, but I wasn't too far behind you, where I came in. And similarly, we had the majority of patients where expected survival was 2 years or less. Now, here we are 25 years later. And I can say for the vast majority of my patients that I expect their overall survival to be greater than a decade. The latest prediction and estimation based on the way we're giving our current therapies is that patients who are younger, of course, who still have a life expectancy of greater than 15 years, are going to live greater than 15 years with multiple myeloma. So there's that quantity that has taken a quantum leap forward. But let me also add that the quality of life has radically changed in multiple myeloma. I remember one of the reasons why I was drawn to multiple myeloma, I was just struck by terribly how the disease affected people. Most of our patients in the clinic waiting room were hunched over and had severe bone pain. We didn't even have bisphosphonates yet as supportive care to help strengthen bones. And patients tragically were so sick through the process. And now, of course, patients can still be very sick with myeloma. I don't want to minimize that. But we have seen with the revolution of immunotherapy and other approaches, the patients are not only living longer, Steve, they're living better. They're able to continue their work, their activities, the things that they love to do. In fact, the vision of the IMF is a world where every myeloma patient lives life to the fullest, unburdened by the disease. And as we try and remove the burden of the disease in myeloma, we're seeing that happen more and more year after year. And lastly, I don't know if I've ever seen a year like this last year in terms of what we've transformed myeloma to become, where patients are getting paradoxically more treatments with more drugs together, but then ultimately less treatments as they're able to either come off therapy or remain on minimal therapy with long periods of remission in between.
So, Joe, the initial therapy of myeloma often involves multiple drugs. Can you discuss what you feel are the optimal regimens and whether everybody should receive these optimal regimens?
Yeah, of course, in myeloma, we never, or in medicine, we never use the word everybody, but I can tell you that the vast majority of patients who are diagnosed with multiple myeloma today, and by the way, we want to work very hard, and I know we'll discuss disparities in a moment, that we capture the disease as early as possible, because so often we capture the disease late. But the vast majority of patients treated with myeloma today as their initial therapy should receive a quadruplet. That is to say, a 4-drug combination that includes a monoclonal antibody, of which we typically use daratumumab or isatuximab, a proteasome inhibitor, which we typically either use bortezomib or carfilzomib, an immune modulatory drug, we typically use lenalidomide, and then some dexamethasone to boot to support the function of those 3 other drugs. And we've proven this, Steve, and I won't bore you with a data dump of all of the trials, but we now have at least 3 huge phase 3 clinical trials for transplant eligible and another 3 for transplant ineligible patients, demonstrating the benefit of 4 drugs over 3. Almost a little bit like HIV, we're proving the principle that more mechanisms of action together will overcome the disease because the biology of myeloma is so heterogeneous and so complex, as opposed to using fewer. And the last point I'll make about this is that when someone says, oh, wow, how can I give my 78-year-old relatively frail patient 4 drugs? It's the way we give these drugs that matter as well, that we can give them at lower doses. We can give them in regimens in ways that are more tolerable for patients. And that paradoxically, with time, they can de-escalate down to much lower doses of drugs and live that longer and greater quality of life going forward. So the short answer is, it's quadruplets for almost all patients. We really have to even change our thinking from, is someone transplant eligible or ineligible, although that's still important, but are they quad eligible or ineligible? And I'm going to suggest that the vast majority of our patients are indeed quad eligible.
Joe, a percentage of myeloma patients will have renal impairment at presentation. Can they still receive the 4-drug regimen? Do you have to modify doses?
Thankfully, the drugs that we use are not specifically interfered with or changed by renal insufficiency, with the exception of lenalidomide, which I'll remind people is actually not renally toxic, but renally cleared. So we do typically modify the dose of lenalidomide, but we've shown, in fact, I just published a paper last year looking at when people were too worried about giving back at those times a triplet and went down to a doublet for sake of renal insufficiency, outcomes were inferior. So we don't want to undertreat those patients because they have myeloma like everyone else, and it can even be more aggressive. So yes, thankfully, again, the vast majority of our patients with renal insufficiency, even those on dialysis with correct dose adjustment, can receive a quadruplet.
You mentioned transplant eligible, transplant not eligible. What are your feelings about autologous transplant now that you have this incredible 4-drug regimen? Should every patient who is transplant eligible receive an autologous transplant?
Now you're going to get me in trouble, Steve, because, we're talking about City of Hope, which has been the bastion of transplant. I was just I hosted a meeting this past weekend, of which one of the key speakers I brought was Amrita Krishnan, who, of course, leads the program at City of Hope in California. And we've had this discussion. I mean, I think we try to have a balanced approach. My approach is as follows. You're the champ, as it were, until something knocks you out. The best outcomes we see with myeloma patients right now who are transplant eligible includes a transplant, but it doesn't mean that absolutely everyone needs them. So I take a couple of caveats. Caveat number 1 is that the best evidence we have for transplant are patients who are 65 years and younger. Not that we're ageist, and we know it's not about age, it's about frailty. But when patients are over the age of 65, we need to be very careful about assessing their transplant eligibility. And I put it this way, I could do a transplant, but should I do a transplant in this individual? Because we know that they're going to be more affected by the toxicity of transplant. Number 2, the shared decision-making model of a discussion with a patient is really important because not everyone needs a transplant right away. They may be able to defer it, especially if they do not have high-risk disease. And then thirdly, we have emerging data coming out that may help us select a group of patients who may not need transplant. I mean, this is hot off the press, Steve. 2 weeks ago, published in the New England Journal of Medicine, the MIDAS clinical trial. And I won't dive deep into it, but the concept of this study led by our French colleagues was to say, if we give people this 4-drug combination and they achieve MRD negativity or minimal residual disease negativity, they then randomize them to just continuing more of the quad or actually getting a transplant. And as it stands now, there's still no difference between those two arms. So it may be possible. Now, we also believe that MRD negativity shouldn't be a single point. We need sustained MRD negativity. So we need some time, and it may not be applicable to highest risk patients. But I often find myself giving permission to some of our patients to say, you don't absolutely have to have a transplant, especially in light of the depth and the duration of response we're seeing with these quadruplets. But for now, transplant is still an important phenomenon. But as I joked with someone last week, Steve, I'm not sure I would be investing in transplant stock right now.
And how are you assessing MRD in myeloma?
So thankfully, we now have multiple studies that are validating the 2 primary models we use now, which is either by next generation sequencing or next generation flow. Here in the US, we tend to have more access to next generation sequencing, and that's the method to do it. And then secondly, the depth of that MRD negativity. We've historically been using 10 to the minus 5, and that is still valid, but we have been showing time and time again, if the technology can be used to leverage 10 to the minus 6, it's even more accurate and more valid to use.
Bispecific T-cell engagers and CAR T cells have had a profound impact on treatment of myeloma. Patients who historically would be in hospice care are now in remission, doing beautifully. I have some friends who have benefited from this treatment. Tell us what you feel about each of these therapies and the sequencing of this treatment.
It really has been a revolution, Steve. And you know, I think sometimes we can be a bit melodramatic in medicine and talk about everything as being a tidal shift, but there is no doubt that the introduction of CAR T-cell therapy was a tidal shift in multiple myeloma. That very same week that we had the New England Journal paper of the MIDAS trial that I discussed, we also had the long-term follow-up of what was called the CARTITUDE-1 trial that even made it to the New York Times, which is not our usual scientific publication, but it was highlighted in the New York Times. And this was because in this clinical trial, they gave that single dose of cilta-cel, which was a CAR T-cell therapy given to patients who on average had had 6 prior lines of therapy. This is a group of patients, Steve, that we would have anticipated in general that their survival was about a year. 1/3 of those patients, 33% of them, 5 years later are completely disease-free, not having been treated again. So you give one treatment and someone goes 5 years without any treatment. It's actually triggered a conversation, Steve, in the myeloma community to say we need to very carefully define the word cure. I'm not saying these patients are cured, but when someone has gone 5 years with no treatment and is disease-free, we have to start thinking about that concept of cure. So I really do think that CAR T-cell therapy is revolutionizing the field. And there's no ideal sequence, as we often say. In fact, I always say, if you want to have a meeting tomorrow, a myeloma meeting, and lots of people come, call it the optimal sequencing of myeloma, because it's sort of a unicorn we're searching. But I think most of us would agree, if patients are eligible, we would like to prioritize CAR T before those other new options, now that we have it even available to us at first relapse. The only caveat I will give to this, of course, is every therapy comes with risk, and I don't want to minimize that. Thankfully, the vast majority of the toxicity of CAR T is within the first month, and we can overcome it in the majority of patients, whether it's cytokine release syndrome, neurological syndromes, infections. We use a lot of IVIG in supportive care, but there is still a small fraction of patients, granted maybe 1% or less, but who develop quite severe neurotoxicities later, things like Parkinsonism and so on. And we're still trying to understand that. There are some new CAR Ts that perhaps don't have that same signal, and that may be the answer. But I don't want to make it sound like it's a pure miraculous therapy. It really has been wonderful, but we still have to keep that in mind.
And do you feel there's a preferred CAR T target in myeloma? Which of the antigens?
Right now, the 2 CAR Ts that we have available, cilta-cels, I've mentioned, the other is ide-cel, both target BCMA. And I think in many respects that has been a preferred target because typically we don't have a lot of BCMA therapies otherwise, although there is an antibody drug conjugate almost definitely going to be approved in the next several weeks in myeloma to come back into the market. But we are exploring other targets, the GPRC5D target, or dually targeting CAR Ts, whether we use CD38 or CD19 along with BCMA or GPRC5D. And then lastly, we have yet another target that we don't have any approved therapies for yet, but one is being developed as a bispecific antibody, and that target is FCRH5. But I think right now we felt that BCMA is likely the best target, but it's very likely in the future that we'll be able to target it better and potentially target two at the same time.
And sequencing of the bispecifics versus CAR T?
Yeah, and so these bispecific antibodies have really had a prolific impact as well. So these, of course, are called bispecifics because they have two arms, one that hooks onto the myeloma cell and one that hooks onto a local T cell to engage it. And what's been remarkable about these products is, although CAR T, we could argue we see response rates over 90% in heavily pretreated patients, we're seeing over 60 to 70% of patients respond to these in a similar cohort, but doing so without the need of collecting their T cells and perhaps even without the need of being at a large academic center. Remember, myeloma, 80% of myeloma patients are treated in the community. So to provide something to patients in the community is very important. And now we have, as of yesterday, we have 4 bispecific antibodies approved in multiple myeloma: teclistamab, talquetamab, elranatamab, and as of July the 2nd, we have linvoseltamab. And these drugs are remarkable because we can give them more gently. We can give them to older, more frail patients who may not be eligible for CAR T. And we're learning a lot about them, Steve, in that perhaps we can give them less aggressively than we historically did of giving them every week, but dropping it down to every other week or even every month, and perhaps even at a time stop to allow patients to have the benefit of it without necessarily some of the longer term toxicities. We know that it can be difficult to go from bispecific to CAR T, hence the general preference of giving CAR T first. But a lot of work is being done on understanding the sequencing of these drugs and understanding T cell health. I always say if you want a great job tomorrow, find a way to create a T cell spa for our patients, right? Where they will have their T cells most beautifully cared for, because we love those T cells. We want to use them. But if we overuse them, it may be difficult to collect them for a CAR T later or switch from bispecific to bispecific. The last comment I'll make here, though, is it is really remarkable how using different targets can also help as well. I mean, of those 4 bispecific antibodies approved, one of them, talquetamab, does target a different antigen on the surface of the myeloma cell, the GPRC5D. It comes with some challenging side effects that we're working through, but perhaps one of the ways we'll be able to overcome that. Another major development this last month in multiple myeloma was the newest tri-specific drug that was presented at both ASCO and EHA, the European Hematological Association. This is a drug that has 3 arms, one that hooks onto GPRC5D, one that hooks onto BCMA, and then the third arm to the T cell to engage it. And perhaps it's pointing to us in a direction, Steve, where we can hit the sweet spot of greater adherence to the myeloma cell, more specificity, but also less toxicity. This drug is now given once monthly, and some of those side effects I mentioned from GPRC5D that we've struggled with, we actually see less in that population. So it may be the way of the future. I don't want to be too crystal ballish or prophetic, but it's amazing how the technology keeps moving us forwards with newer bispecifics, maybe trispecifics, newer CAR Ts to take this incredible modality that we have now and make it even better.
Joe, prolonged hypogammaglobulinemia is a problem, a concern, both with CAR Ts and with the bispecifics. Do you see more with one or the other?
It is absolutely an ongoing problem for sure, because as we hit these myeloma cells, we inevitably hit the good immunoglobulin producing plasma cells. We do see it quite dramatically after CAR T, but with time it can improve because it was that one-time infusion. In the early days of Bispecifics, we were giving them simply every week. It was profound in just about every patient, and we just had to give IVIG once monthly. And even then, some patients did experience infections, and some even fatal infections. I think we've become a little bit better now by giving the bispecifics less frequently and sort of backing off a bit on constantly hitting those plasma cells. But it does continue to be an ongoing challenge, and one that we have to educate the community, as a lot of patients are moving back into the community with this, educating patients to know the signs and symptoms of infection so we catch it earlier. But my hope is, as we use more precise targeting and as we use these drugs less aggressively, we'll be able to have less of that hypogammaglobulinemia. I say it all the time, Steve. You and I have been in the myeloma community for over 20 years. There is no drug we use in myeloma today the way it was first introduced, meaning we have always typically use that maximum tolerated dose model. And later on, we realized maybe it was higher than we needed to give it. So we used to give, bortezomib twice weekly. We typically give it once weekly now. We gave higher doses of selinexor. We give lower doses now. We used to give bispecifics every week. And eventually, I imagine, we'll be going down to once a month and maybe even time stopping them.
It's interesting. Back in the 1980s, I established a myeloma cell line system that's been used in probably several hundred laboratories and academics and in industry. And it was focused on steroid sensitivity and resistance. And for about 20 years, I'd heard nothing because Northwestern had licensed it to companies, but we gave it free to academic institutions. And then I started to get royalty checks, which I still get to today because of all these incredible advances. And it is quite remarkable how the field has evolved. Let me ask you about supportive care. It's always been a very important component in myeloma therapy, in particular bone health. What has evolved in terms of improving the bone structure of these patients as they go through all these therapies?
I'm so glad you mentioned that, Steve, because without sounding like a commercial, I say this all the time, and I try to teach this to our residents and to our fellows. I don't treat myeloma. I treat people. And we have to look at the whole of the individual, their spiritual health, their psychological health, their sexual health, and of course, their physical health. And a lot of that has to do with the organs that get affected by myeloma, whether it's the kidney, whether it's the bone, whether it's their immune system. And bone disease in particular, I commented earlier, didn't I? When I started a myeloma, I look out into the waiting room and almost every patient was hunched over. Many of them had braces on their chests because we didn't have a lot to do. And myeloma, when advanced, of course, can damage the bones terribly. So I would say two major advances have been, one, as we control myeloma better, we can control the bone disease better. There's no doubt that those two things are inherently connected. So it's fascinating to me that as we treat people with these quadruplets and with these newer therapies, and we get them into remission more quickly and more deeply, we're actually seeing less of the downstream effect of the bony effects on them. But secondly, and very importantly, providing bone-specific agents. We now have not only bisphosphonates that we almost routinely use in all of our patients, but we also have the introduction of denosumab as a drug that is particularly helpful when patients have renal insufficiency. As you commented earlier, a third of patients at diagnosis of myeloma do have some degree of renal insufficiency. So this has now resulted in a situation where we are seeing less burden of bony disease early on and a rapid turnaround of that bony disease as we treat patients. Now, that being said, there's still, unfortunately, patients that suffer dramatically. I think part of the solution is going to be earlier and more accurate diagnosis. I have been, in some of the work that I commented on that we do at the IMF, especially our Empower program, which is designed to reduce health disparities. Part of the great disparities we see is the delayed diagnosis. The average myeloma patient sees their primary care provider 3 times with signs and symptoms consistent with myeloma before the diagnosis is made. That's longer in African American and Latino American patients, often because of coexisting things like diabetes, less access to primary care, less trust within the medical system. So I think one of the ways in the future we'll be able to further reduce the bony burden of myeloma is to catch the disease earlier. And who knows, maybe someday we might even be screening for myeloma, but that's, fodder for another podcast on a different day.
So along those lines, Joe, say an individual has high-risk smoldering myeloma, which to my understanding, about half those individuals over a 2-year window, evolve into classic myeloma that requires therapy. Your thoughts on early intervention versus observation?
I mean, I think it's a fantastic question and one of the hot topics of the day based on a very important clinical trial that was reported at ASH and published, the Aquila clinical trial. So quick recap, of course, we have this huge spectrum of myeloma from MGUS or monoclonal gammopathy of undetermined significance to smoldering myeloma to active myeloma. But even within smoldering myeloma, we have a spectrum because we all realize that the biology of myeloma is highly different in every patient. We have some patients that have a little schmutz of disease that'll never grow. Others, it grows very quickly. I sometimes liken it to running towards a cliff. It depends on how far away you are from the cliff and how fast you're running. And we used to define myeloma by saying, well, you had to fall off the cliff. You had to have crab. I can hear Maury Gertz in the background saying to me, show me the crab, because we had to have had it. We changed our diagnostic criteria just over 10 years ago through the International Myeloma Working Group to say, no, it's not full crab. It's so-called slim crab, which was the contribution I made, by the way, to the myeloma community, Steve. I came up with the acronym slim crab. I can drop the mic and retire, but no.
Maybe you can share with everybody what CRAB stands for.
Right. So CRAB is calcium elevation, renal or kidney damage, anemia or low hemoglobin, or B, bone disease. So it's an acronym. And we added 3 things to it: SLIM, S standing for 60% plasma cells, LI standing for a light chain ratio of greater than 100 of the involved over uninvolved light chains, and M standing for MRI, demonstrating more than one focal lesion. And so the idea there in that same analogy I gave was to say, okay, if someone's running so close to the cliff and they're 50 feet short of the cliff, let's not wait until they break a bone. Let's not wait until they have renal insufficiency. Let's consider that active myeloma and fully treat them. But what if those patients that are, let's say, between 200 and 50 feet short of that cliff? Do we just wait and watch? Do we just observe? We know that they're heading towards the cliff. Perhaps we can intervene with something less aggressive, and we may be able to prevent them from ever crossing the cliff and ever developing myeloma. And that was the principle behind this Aquila clinical trial that compared 2 strategies in that high-risk smoldering population. And part of the challenge is, how do we define that? We've typically defined it through the Mayo criteria of what's called the 2-20-20, which means either someone has 2 out of the 3 factors of an M spike greater than 2, more than 20% plasma cells, or a light chain ratio of greater than 20. And this trial compared giving 3 years of single agent daratumumab to just actively observing and observing, I must say, Steve, very carefully and very well. Every 3 months labs, every year a PET scan, every 2 years a bone marrow. And the short answer is that study clearly showed that patients could have less myeloma progression when given the single agent daratumumab. At the 5-year mark, 2/3 of them had still not developed myeloma, whereas only 40% in the observation arm. And so it's allowed us to say this is yet another option. We had an ODAC recently, still waiting on formal FDA approval, but we had an ODAC around this that supported the notion of the benefit-risk ratio of giving single agent daratumumab. So to directly answer your question, I think it's a decision that is made, as with everything else, between the provider and the patient. I would not say that absolutely every high-risk smoldering myeloma patient needs to be treated tomorrow with daratumumab, but that conversation has to be had. There's some who has to be had. There are some patients who might say, can we just wait a little bit longer, doc? Others say, no, I want to do something now. This is the time you give me a less toxic therapy, like one drug, and it kicks the can down the road. I had a patient the other day in his late 70s. He says, look, if you kick this can down the road, I'm enjoying my best life now. I'm having fun with my grandkids. I'm enjoying my retirement. I can handle a drug once a month as opposed to going through full therapy or having this on my mind that any minute I might develop active myeloma. So it's an area of ongoing research and work, but it just gives more options for our patients.
Joe, in our last few minutes together, tell us about health disparities as it relates to myeloma, both in the United States and internationally, and also the issue of financial toxicity, which has come up repeatedly both in our country and internationally.
Absolutely. I mean, it is really a massive problem, Steve. And I know that You know that one of the things I've dedicated so much of my career to is helping to reduce these health disparities. I start by reminding people the unfortunate facts that myeloma actually is arguably the most disparate cancer within the African American community. And this is personal and professional for me because, as you see from the map behind me, I'm of African descent. And so individuals of African descent are twice at risk of developing myeloma. So the incidence is twice as high, but as is their mortality, which means a Black man or a Black woman diagnosed with myeloma today is expected to live half as long as the same aged white man or white woman. And we know that's entirely unacceptable. And a lot of that has to do with the social determinants of health and health in general, but also myeloma specific, the delayed diagnosis and the reduced access to therapies. All these great therapies we've been talking about, CAR T-cell therapy, autologous stem cell transplant, great combinations of drugs and even clinical trials, we've shown, unfortunately, have had reduced access within the African American community. And so this has led to that disparity. There's also a significant disparity within the Latino American population where the diagnosis is delayed, the diagnosis is made at a younger age. And as you noted, internationally, this has a lot to do also with delayed diagnosis and reduced access. So I've been very passionate about this. I know that one individual or one organization can't fix it all, but we've had the privilege. I created a program called the MPower program. It's a bit of a play on words, myeloma-power, meant to empower communities to change the course of myeloma. What we mean by that is to reverse these disparities. We do it with three big pillars. One pillar is to engage the community, to raise awareness. Just a couple of weeks ago, Steve, for Juneteenth, I was at a church in New York City where we were raising awareness around myeloma within this community, for people to know what are the signs and symptoms that they should talk to their doctor about, what options are there to help patients with myeloma. Number two is to educate the primary care world to reduce that time to diagnosis so that they recognize, do you order a serum protein electrophoresis? Do you order a light chain? How do you order it? And in whom should I be thinking about myeloma, in particular in younger African American or Latino American individuals who have some of the signs and symptoms of myeloma? And then lastly, to enhance the care of patients with multiple myeloma, providing greater access, influencing the workforce. We have this program we're about to meet next 2 weeks where we've taken medical students from historical Black colleges and universities and paired them with a myeloma doctor who's interested in health disparities to do a project together. And then we bring them all together at the annual meeting of the National Medical Association. They present their work. Steve, it's been remarkable, the projects they're doing. Two of them last year got Abstract Achievement Awards at ASH even for the great work that they're doing. So it's a massive problem. We can't fix it overnight. It took hundreds of years to develop, but we can make a difference. We can, at the earlier diagnosis, at greater access to therapies and providing more cultural competency. Part of that toxicity, as you noted, is indeed financial. Whether it's through the healthcare system, whether it's as I mentioned, social determinants of health. I tell the residents and fellows all the time, you can have the greatest drugs, but you're not going to have a good conversation with your patient if that very patient of yours is hungry at the time, or doesn't have the support from their family, or has housing insecurity. And so one of the ways as we see these new drugs come out, and inevitably they're very expensive, is we have to really look at the financial structure. How do we provide these drugs? What are the ways that we can ensure greater access to them? Of course, that's another huge challenge in and of itself, but one that is not insurmountable. As we live in such a wonderful, successful country, we need to find ways to address this more concretely.
Joe, as we say goodbye to our viewers, I want to sincerely thank you. That was just a remarkable overview of myeloma and your insight, and I am so appreciative of your participation.
It's absolutely my pleasure, Steve. I'm so grateful for you as a person and for all that you've done in your career, and for me and for so many others. But to be able to share these kinds of things and recognize that our patients are at the center of all of this, I hope will be helpful to your viewers and have an impact.